And so thank you very much for having me here, Sandra. Very excited.
Yes, it is. Well, you have an impressive bio. So why don't you tell us a little bit about yourself first? We want to get to know you personally.
Sure. So I've been in, actually, let me agree to this. I've been in practice here in Rockland County for about, believe it or not, about 17 years now. And I'm originally from, actually my family's originally from the Caribbean, from Jamaica, and actually lived there for a while. But obviously I've been here for a long time and grew up in the New York area. Went to school in the Northeast, as you mentioned, went to school and trained at Montefiore for cardiology fellowship. And sort of interesting that I left Montefiore, came to Rockland County, and Montefiore kind of circled back in becoming affiliated now with Nyack Hospital. So in a way, I'm kind of back at Montefiore again, being part of the Montefiore Nyack Highland Medical triumvirate, so to speak. And by the way, the quadruple board certified thing is fancier than it sounds. It means that you have certification in 4 different disciplines of, in my case, in cardiology, general cardiology, and also in 3 subspecialties of cardiology. So nuclear cardiology, echocardiography, and cardiac CT.
Yeah, so you've been busy in school, I guess, doing
Been
all
busy.
those specialties.
Yes. Very, very busy.
Of course.
And you never stop learning. You're always learning and always, gaining new knowledge. So that's a given with our profession.
And I think that this is what happens when you're in the healthcare field. Like, there are so many advances, right? And things happen very quickly, day after day. There is so much research and many new discoveries happening that, of course, it's hard to keep up with everything. So the only way that you can really keep up is keeping yourself in a school.
Yeah. And honestly, that's what I love the most about cardiology, is the fact that there are always new advances, whether it's in medical treatment, technology, whatever it is. It's always a rapidly advancing field. So it's very exciting to be a part of it and to share the knowledge that, I've attained with patients, most importantly.
And what is the heart anyways, right? It's only a heart.
Yeah, minor organ.
Minor organ, yeah. Yes. So let's get into business. So there are so many things that affect heart health, I think. So one of them is family history. So how does family history affect heart health?
So, I think most people are familiar with many of the risk factors for heart disease. And, I sort of divide them into what we call controllable and uncontrollable risk factors, with the controllable ones being the things like the diabetes and high blood pressure and things we can talk about a little bit more. The uncontrollable risk factors are the things that obviously you have no control over. And family history is one of them. You're not, you can't control who you were born to, who your parents are, where your genes lie. And that's why family history is so important, because many people, some of whom are seemingly healthy and do all the right things, still get heart disease. And one of the reasons for that is that there's a genetic component through their family that predisposes them. And that's why when we get a history as cardiologists from patients, the family history is a big part of it, because it may reveal some risks there that someone may not be aware of. What I find interesting about family history, though, is that sometimes it works the other way, where it's overstated. I'll see patients in the office who come in and they've carried this kind of paranoia about their family history for, whatever amount of years. And then when you talk to them, yes, they have a family history, but it's, there's a 2nd degree relative, or, even a grandfather, but had heart disease in his 80s and died from a heart attack in his sleep when he was 89. And, that's not, heart disease is so prevalent that, especially at an older age, that having a family history like that may not necessarily, carry excess risk. So there's family history and then there's family history. So for instance, if someone comes in and said, you know, my mother had a massive heart attack at age 48. I had an aunt, you know, related to my mother who also had an MI in her 50s. That carries a little bit more of a significance, because then you're really kind of thinking maybe there is something more genetic, familial that, you know, may have been transmitted to you as the patient that puts you at higher risk. So I guess my point being that family history is kind of a generic term, but when you get the details, it may have more significance in one patient than it may in someone else.
And then, Dr. Brian, if I'm understanding correctly, can we summarize what you said in, you know, the fact that family history also has to do with age? Like if your family members have died of a heart attack, let's say at an older age, then it's less risky for you to have heart disease than family members who have suffered heart attacks at an earlier age. Is
Right.
that correct?
That's correct. So if someone has what we sort of term as premature coronary artery disease, so you have family members who, let's say before the age of 55, had cardiac events, especially if those family members didn't have a lot of other excess risk factors. They didn't smoke, they weren't diabetic, you know, may have been seemingly healthy and had a heart attack in their 40s. Yeah, to me, that itself would make me more concerned about any individual patient and talk to them and assess them with that in mind to make sure that, again, that's a risk factor you have no control over. But what that means is everything else that you can control, you need to be even more diligent about addressing those issues.
Mm-hmm. And you're talking about diabetes. So being that diabetes is such a prevalent condition, especially here in the United States, but you know, it's really prevalent around the world. So how does diabetes affect your heart?
Yeah. Well, you know, you talked about the prevalence of diabetes. I think one main reason for that, what goes along with the prevalence of diabetes, is the prevalence of obesity and the epidemic of obesity that's not only taken over, you know, the United States, but as you said, around the world. And with that goes the risk of diabetes. And diabetes is one of the major risk factors for heart disease because the effect it has on your metabolism, the effect of having high glucose levels on your arteries, promotes the process of plaque formation in your arteries that can cause not only just coronary artery disease, but arterial issues throughout your body. And again, one of the controllable risk factors that, you know, I think is often not, you know, many people have diabetes, many people are treated for diabetes, but it's not just to know you have it and being treated, but also to know that it's actually being controlled. And there are people who could significantly reduce their risk of the effect of diabetes on their cardiovascular system by being, you know, adequately, you know, addressed in the medical system.
And what will be the relationship with high blood pressure? I feel like, you know, a lot of people say, oh, I have high blood pressure, but they don't really know what high blood pressure really means. So would you mind explaining, you know, what's heart or what's blood pressure, what's high blood pressure, and then how it relates to heart disease?
So yeah, so one of the other, you know, major risk factors for heart disease is hypertension. And you know, hypertension basically refers to elevated blood pressure within your systemic arteries. And really the role that it has, along with the other risk factors that we talk about, is that it promotes changes in your vessels that could promote, well, hypertension in particular, thickening of your blood vessels, but it also promotes, again, the process of plaque formation within your vessels. You know, hypertension, they call it, you may have heard the term the silent killer, and it's that for a reason, because often people that have high blood pressure aren't aware of it. So it may not cause symptoms unless it's really significant. People may get headaches and other symptoms related to it, but oftentimes people have no symptoms whatsoever, though over the years it's promoting these changes in your arteries that can increase your risk of vessel changes that can cause issues with your vision, with your kidneys, with your vessels that can promote, again, coronary artery disease, aortic aneurysm. So a very important risk factor that's exceedingly prevalent. It seems like the majority of the adult population in the United States develops hypertension at some point. So it is definitely one thing that, if it's addressed, can also significantly impact, reducing the risk of cardiovascular issues that we see.
Mhm. And that's related to cholesterol as well, correct?
Yeah, so they kind of work together. So, what I kind of counsel people on is that there's no, so for instance, so someone has high cholesterol, and there's sort of this misconception with cholesterol that if you have high cholesterol, it causes sludging or clogging of your arteries. And it's really a misconception, because there are plenty of people with normal cholesterol levels who get heart disease, and vice versa, people with elevated cholesterol that don't. And really, because it's the interplay of all these different risk factors and the effect that it has on your vessels that leads to heart disease. So the actual pathologic issue that causes heart disease, and when I refer to heart disease, I'm specifically referring to coronary artery disease. But the actual pathology is that you're developing atherosclerotic plaque within your arteries. And there are many factors that contribute to it. Now, cholesterol is one component. So when you have high cholesterol, it kind of increases the gradient for cholesterol particles to get into your vessels. And that promotes the beginning of this inflammatory process that causes a recruitment of, some of the cells in your body, calcium, cholesterol particles, and it sort of forms this whole milieu of stuff that causes the artery to get secluded. But again, it's not just one individual thing. It's high blood pressure, it's diabetes, it's high cholesterol, it's smoking. All those things are kind of at play in terms of promoting this process. So these issues are separate, or they're different issues, but they kind of play together to cause heart disease. And the more of these individual risk factors that you have together combined, statistically increases your risk. So whether it's, if you just have hypertension versus, so if on top of hypertension or diabetic, you smoke, those are just additional things that statistically will increase your risk. Doesn't guarantee cardiac disease, because again, there are people that have, and we've all heard the stories, people who are seemingly healthy, 45 years old, run marathons and drop dead from heart disease. So there are definitely other factors there beyond the typical risk factors that can lead to this, but definitely the more of them you have, statistically, the higher risk you are of having these issues.
And Dr. Brian, what would be the relationship between stress and heart attacks, for example? Because, as a Latina myself, it's very common among Latinos to say, oh, I have a lot of stress, I'm gonna get a heart attack or something, like, oh, you're gonna kill me of a heart attack with the news. So is that true? Like, bad news, stress can kill you from a heart attack?
It can. It's funny, because whenever I ask that question in the office, I don't think I've ever encountered a patient who told me they were not under stress. And to a degree, it's true. I think it's an issue with the lifestyle that we live in this country in general, where it is a high stress lifestyle. People have stressful jobs, they have stressful situations at home, they have kids, we're running this place and that place, and we're, sort of putting our bodies constantly under stress. And the stress kind of, I think, leads to cardiovascular issues kind of in two ways. One is definitely physiologically, it has an impact. Certainly stress, may increase levels of inflammation in your body. Stress can elevate your blood pressure, which in and of itself, as I said, is a risk factor for cardiovascular issues. The other thing I think that stress does, though, is that it promotes a lot of unhealthy habits and behaviors. So what do we do when we're under stress? We tend to, eat more, eat poorly, drink more alcohol, sleep less, smoke. So all those things are sort of secondary effects of increased stress that, in and of themselves can lead to heart disease. So stress is definitely, again, while it is a it is a modifiable or a controllable risk factor to some degree. It's something we all deal with. And I think that's one of the things that I think is probably not discussed enough. I think in talking to patients, it's sort of addressing how dealing with, excess levels of stress can actually reduce their cardiovascular risk. And again, directly and indirectly, because again, it leads to these behaviors that I talked about that, I think if we were under less stress, we'd probably be less likely to fall victim to it.
Yeah, so it's like the stress actually triggers risk factors that eventually will give us heart disease.
Correct. No, definitely.
Okay. So now tell us a little bit about the symptoms. Like, what do we need to feel to seek a doctor?
Mm-hmm. Well, let me start by saying, first of all, I think for one, I wouldn't necessarily wait for symptoms. So what I normally tell people in terms of, seeing and that's a reason why you see whether it's a primary care doctor or a cardiologist sort of proactively, is that the best way to really treat heart disease is to not get heart disease in the first place. So, I think seeing a doctor and being told about these and being aware of these risk factors and addressing them to prevent heart disease in the first place is kind of, how you want to go about it. Now, in terms of what to look for, I guess your specific question was, what are the symptoms of heart disease? Mm-hmm. So heart disease, let me sort of categorize things first of all. When we use the generic term heart disease, people are often specifically referring to coronary artery disease, because it's sort of the most common thing that we talk about and the thing that people fear most. So I'll start with that first. When we talk about coronary artery disease, one of the typical symptoms people may get of that is chest pain. So as cardiologists, whenever we hear someone complaining of having chest pain, particularly triggered by exercise or activity, and that's because, at rest, the heart might be okay, but when you're actually exerting yourself and increasing your heart rate and your blood pressure and the heart needs to work harder, that demand on the heart may outstrip the supply of blood flow, and people may get symptoms. So certainly any cardiologist hears the symptom of exertional chest pain, sort of the alert bells go off. That being said, some people also have what we may call an anginal equivalent. So their symptoms may not manifest as chest pain, but it may manifest as other things. It could be shortness of breath. It could be fatigue. It could be a change in their exertional tolerance, like how quickly they get tired when they exercise. And clearly, if it's a change from what they had noticed in the past as well. And also keep in mind that when we talk about pain, it's not isolated to chest pain. Some people can get jaw pain. Some people can get shoulder pain. And we've all heard, the idea that women often have more atypical symptoms than men, which is true. Sometimes it's overstated, but it's definitely true. I think the important point, though, is coming back to that exertional trigger. So if you get any pain anywhere, whether it seems a little bit strange or unusual, but it's specifically triggered by exertion or activity, should at least raise a question to where, you might decide to get checked out either through your primary doctor or cardiologist. It may end up being nothing, but it is worth evaluating. So any kind of chest pain, shortness of breath triggered by exertion, anything different from what you're used to, any change in pattern, even fatigue, things that you didn't notice before, all should be signs that, you may want to get checked out. And again, these are symptoms specifically related to coronary artery disease, but in relation to other cardiac problems. If someone has suddenly an irregular or rapid heartbeat, if they have signs of swelling in the legs, edema, shortness of breath lying flat in bed at nighttime, those are all kind of symptoms that might indicate an underlying cardiac issue. It may not, but it should at least warrant getting evaluated.
So, and we have a question here from one of our participants, Unique. She's asking, when someone has just been diagnosed with high blood pressure,
Mhm.
how much time do they have to change their diet and lifestyle before they 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 should be put on medication?
Um, I think it partly depends on how significant the elevation is. I think for most physicians, and actually based on guideline recommendations, we often don't make the diagnosis of hypertension based on one recording. So, someone may come into the office and have a blood pressure of, 135 over 84, let's say. And uh, and by current guidelines, that is considered hypertension, whereas in the past it wasn't. But it doesn't necessarily mean that even if you have the diagnosis of hypertension, that it warrants medical therapy right away, because we also want to foster an idea about lifestyle changes. So the first thing I typically would do is discuss the things that can help lower the blood pressure. So reducing your dietary sodium intake, regular exercise, weight loss if it's appropriate, and then having the person come back in a period of time and reassessing the blood pressure and deciding if they need to go on medication. You also have to keep in mind there might be specific factors for that day that might have caused the blood pressure elevation. If the person was in pain for some reason, the downside of that is when people come in, there's always an excuse. So, I'll see someone with elevated blood pressure and they'll rattle off the list of 5 different reasons why their blood pressure was high, all in an effort to stay off medication. But, we'll work with that. They don't necessarily need medicine right away, but as long as you're going to see the person back again, and if it's persistently elevated despite the lifestyle measures or changes, then they may warrant medication. On the other hand, if someone comes in with a blood pressure of 200 over 110, that's not someone you're going to send home and say, come back in a month and let's check it again. And someone like that may need therapy right away. But as long as the patient is willing to follow up, they kind of get the issue, they're willing to kind of make a change from a lifestyle standpoint, then, in most cases, it's not necessarily an urgent issue that has to be addressed immediately with medication, but it shouldn't be ignored. And as long as there's appropriate follow-up and follow through, then it may not need treatment right away, but may with follow-up.
Mm-hmm. And continuing with the blood pressure questions, Patrick is asking if you've been taking medication and you've been under control for a long time now, can you start reducing the medication or maybe take it every other day or only 5 days of the week?
So not really. So, high blood pressure is, again, it's a controllable risk factor, but the key word in that is the control. It's not necessarily a curable risk factor. And in saying that, so certainly with the lifestyle changes so if someone comes in and I see them and they're hypertensive, but they admittedly have a high sodium diet and they're overweight and they address those issues and they come back, even if I had put them on medication to start with, if someone has sort of demonstrated that they've made those changes and we see an improvement in the blood pressure, yeah, sometimes people could come off medication because you may expect a different result off medication had they made those changes. Now, if someone just simply starts taking a pill and takes it for 3 months or 6 months, and the blood pressure numbers seem improved, once you stop the medication, what's going to happen? Predictably, the blood pressure is going to go back to where it was before if there have been no other changes. So typically, high blood pressure meds are for long-term management and maintenance. But there are scenarios where, again, if there are lifestyle changes that might make you expect a different result, then it may be appropriate to take people off medication down the road. But the key point is that it should be done in conjunction with your physician and not on your own. And for most blood pressure medicines, you're either on it or you're not. So this idea of maybe taking it every other day or as needed really doesn't work. It should be either you need it. If you do, you take it. If you don't, your doctor may work with you to get you off the medication.
And I understand that your blood pressure is controlled because you're taking the medications,
Mhm.
right? Like, and that's the reason why you have to take them daily, because if you skip them, then that day you skip, your blood pressure is probably gonna go up. So
Right,
you really
right,
need, the reason why it's controlled is because you're doing a good job with the medications, taking
right,
them.
right.
Okay.
And there's some medicines in particular that if you do that, if you're taking them and then either stop them suddenly or take them intermittently, sometimes you can actually have a rebound effect where your blood pressure is even worse than it might be otherwise. So there's certainly not meds that you should take and stop on your own without the consent and advice of your doctor. And if you are going to go off of it, be told how to go off of it, because some medicines you might actually want to taper to off rather than stop suddenly.
Yeah, so please don't do it. And in the meantime, Jill is asking if swollen ankles are a symptom of potential heart issues.
Yes and no. So one of the most common reasons we as cardiologists see people in the office is for that same issue, is for leg swelling or edema. And while edema can be a sign of cardiac issues, and it can be a sign of congestive heart failure in particular, um, in most cases, it's not a cause for panic. We'll see people coming in or calling on the phone, requesting a same day appointment because they notice swelling in their legs and they're worried they're heart failure. And while that may be the case, more often than not, there's some other etiology. There are medications that as a side effect can cause leg swelling. People can have leg swelling because of vein related problems like venous insufficiency. People can have leg swelling because of dietary issues from a sodium binge or high salt intake. So that being said, it should be evaluated because there are cases where it is reflective of a cardiac issue such as heart failure. So if someone has a heart muscle that is not pumping properly, or they have a heart muscle that's stiff or is not compliant and doesn't accommodate their blood volume as well as it should, they may be prone to you could think of it almost as backing up a fluid within their system that then filters down into the legs and can cause swelling in the legs. So that can be a sign of this problem or heart failure, but by no means does swelling necessarily mean heart failure where it should be a cause for panic, but certainly should be evaluated. It can be a sign of a cardiac issue and should be looked at.
So let's get into the meat and bones of this chat. What
Mhm.
tests do you do or do we need done in order to detect heart disease?
So within cardiology, we have, our a whole complement of fancy examinations and testing. The first thing that I tell people to do or be aware of is that they're simple things, just that when you see a cardiologist or a physician, one of the initial things we do is just a simple physical exam that could pick up cardiac disease issues. So obviously, simple things, measuring your blood pressure could diagnose hypertension. When we listen to your heart, we may hear a heart murmur, sounds that might indicate you have, a valvular problem, a heart valve issue. We listen to your carotid arteries in your neck, where we can hear if you have what we call a bruit, that could indicate plaque buildup or blockage in the arteries in your neck. We check your abdomen to see if there's any sign of aneurysms in the aorta. And we check your legs, because that could be a sign of circulatory issues. If you have poor pulses, we check for swelling in the legs, as we just talked about before. So I guess my point is, even before you get to actual tests, just a simple physical exam might indicate underlying cardiac issues. The simplest test that we probably do in the office is everyone's aware of an EKG or an electrocardiogram. And what an EKG is basically it's a brief representation of the electrical activity in your heart. And the main thing it looks at is your heart rhythm. So we can tell if someone has a problem like atrial fibrillation or some sort of arrhythmia, if it's happening at that time.
Mm-hmm.
So you can have a completely normal EKG in the office, by the way, and still have major heart issues. So by no means does a normal EKG mean you have no heart problems. So it's good at indicating active cardiac issues like an arrhythmia, or if you're having active lack of blood flow to your heart, or it can detect past stuff. So if someone had a significant heart attack in the past, sometimes on a baseline screening EKG, you might see some evidence of that. But again, it's limited. You can have, again, significant heart disease but have a normal EKG. So that's why we do additional testing on top of just a simple electrocardiogram to get more information. One of the other basic office tests we'll do is something called an ultrasound or a sonogram of the heart. And that's the one similar to when women are pregnant and you do an ultrasound where you can see the fetus. You can do the same thing of the heart where you look at your heart muscle function and strength. You can see the valves in the heart. So if someone has a heart murmur, you can do the echo to see if they have a heart valve problem. And you can generally see the blood flow within the heart itself. What it does not tell you is whether you have issues with the arteries in the heart. So an echocardiogram is limited in that fashion. So again, you could have a completely normal echocardiogram and still have significant coronary artery disease. So I think what you have to know is what the information that the test can tell you, what it picks up, but also know what it doesn't pick up. So don't necessarily be reassured that just because you had this or because that all sorts of heart disease issues, have been ruled out.
Now, who makes that decision, Dr. Brian? Because indeed, I know of cases that has happened. The person is not feeling well. They have an EKG done and they're like, oh no, you're fine, go home. And later on, they die of a heart attack in less than 24 hours. So obviously, as patients, we don't really know what is happening. So I guess doctors will make that decision, but how do we prompt doctors to search a little or dig a little bit deeper into finding something? Because you have said it yourself, sometimes everything appears to be normal, but it isn't. So how do we troubleshoot that?
So, the test I mentioned, the EKG in particular, is part of a general physical exam. So if someone's not really having any symptoms, that might be done routinely. And if it's normal, then there may not be any need for any additional testing. Now, the problem with heart disease is that unlike, things like other disease states like breast cancer or colon cancer, where there are standards for screening. So you turn, I believe it's 40 as a woman and you start getting regular mammograms. Now it's 45. For the general population, you get screenings for colon cancer. There really is no such thing in cardiology where you turn a certain age and you need to have this, and that done. So it's very much individualized. And that's the reason why when you see your physician, whether it's your primary care doctor or cardiologist, what's recommended is very much personalized. So there might be one patient that comes in and all they need is an EKG. And if they're fine, they have no symptoms, they have no family history, you can reassure them that there's really no sign of an issue and nothing further needs to be done. However, a very similar patient comes in, but also says they, again, have this family history of early heart disease, or they smoke, or they're diabetic. You may have a higher degree of suspicion for heart disease, even in the absence of anything else being abnormal, and you may send them for other testing just to look for heart disease issues. Now, of course, if there's anything abnormal, they have an abnormal EKG or they present with symptoms, then any patient should have further testing done. But let's stick with the asymptomatic patient first to answer your question in terms of who gets further testing. If we deem you to be at, if you're high risk, then it's a different story. You may need to have certain testing done anyway, but the generic patient that comes in, we may select some patients to have additional testing done. And one of the popular tests that I use quite frequently and people get on their own is something called a coronary calcium score. And what it really is, it's a screening test for coronary artery disease. It's a CAT scan that's done of your chest. And you get quantified, you get an actual number of how much calcium is associated with the arteries in your heart. And that's important because calcium follows plaque. So the higher the calcium score is, you get a higher sense that the person has some plaque burden within their coronary arteries. And you actually get a score from 0 to 1,000. you want to be zero. It's the one test where you want to be a zero because that means there's no evidence of any calcified plaque in your arteries. As that number goes up, and certainly when it goes over 400, it kind of indicates that there's more of a plaque burden there. And it's important information to have because you may, it's all about risk stratification. So there might be a patient that comes in that you might previously think was low risk for having a heart attack. But after doing that test, if the calcium score is elevated, that person may now be stratified as someone who's at much higher risk. And you may look at them differently, you may treat them differently in terms of medications. And most importantly, it also is a red light to the patient that they've got to change things from a lifestyle standpoint. They've got to take ownership and they've got to make changes to reduce their risk long term. So that's actually a good screening test that we do now to look for any signs of early heart disease in asymptomatic patients, the coronary calcium score. And that's one test it's not for everyone because there has to be a treatment decision made from the test. So if someone already is diabetic and they smoke 2 packs a day and they're generally high risk, you're going to treat that patient aggressively regardless anyway. The calcium score may not change your assessment of them, but someone who's maybe more low to intermediate risk where the information might change how you view them, that might be an ideal patient to consider doing a coronary calcium score.
And all these tests that you're talking about, are they covered by insurance?
Very good question, especially as it relates to that test in particular. The coronary calcium score is typically not covered by insurance. Not really sure why. Fortunately, the cost of it has come down significantly over the years. And at most places, at Nyack Hospital, I believe you can get it for as little as $99, less than $100 reliably. And, it's one test that there's no IV, there's no contrast. It takes a matter of minutes and it's affordable. And it actually gives a lot of information that may change not only how your doctor views your heart risk, but how you should view your heart risk. And it can promote action. But that test in particular is not covered generally by insurance. Most of the other tests that we do, the office tests, EKG, echocardiogram is covered by insurance. Many times it does warrant pre-authorization where the office has to get approval. It's very rare that it's an issue where the patient gets stuck with the cost of the bill, but those tests certainly are. And then some of the more advanced tests that we do, whether it's nuclear stress testing or more invasive stuff, again, in the appropriate patient is also covered by insurance.
And what's the prep for some of these tests? Because some people are scared of the preparation. Like for example, when you're going to have a colonoscopy or something like that, the prep the day before is agonizing. So what about these tests for the heart?
Most testing doesn't require much preparation. So the office testing that we do for the most part requires none. There are tests we do like screening for abdominal aortic aneurysms where there's an ultrasound of the abdomen where they may not want you to eat for several hours before. I'll mention some of the other testing that we do as cardiologists as well. So when we evaluate people, I mentioned the asymptomatic patient, the coronary calcium score. In people that have symptoms where we'll want to do like a nuclear stress test where the person may need to receive a medication to perform the stress. Oftentimes, they may need to be NPO for a few hours before. We'll give instructions on whether they should or shouldn't take certain medicines. So for stress testing, when we have someone exercise on a treadmill, let's say, where we want to increase their heart rate to be able to get a judge of their heart performance, the preparation may involve not taking certain heart medicines like beta blockers or calcium channel blockers. But these are instructions that we specifically give for a particular patient, knowing what their medicines are so they're prepared. But in terms of your general question about preparation, it's not like a colonoscopy where, we love the prep for that one. There's nothing like that in cardiology where you're tortured for 24 hours before. It's usually at most for the more advanced testing, maybe being NPO or something like that, or holding a medication, or for certain tests, there's certain medicines we may have you take before you have the exam done.
Okay. And let's talk a little bit about when to visit the doctor, in the sense of, if you're feeling symptoms, when you really need to go to the emergency room versus waiting for an appointment with your primary care or your cardiologist.
I think, and along the same lines, one thing I will say is, over the past year and a half, obviously COVID has been at the forefront of the headlines, and we've seen a lot of people delaying being seen for symptoms because of their fear of going to the hospital for COVID. So we had a lot of people who needed to go to the hospital, sometimes in an emergency setting, that didn't because they were afraid of COVID. I think we've largely gotten beyond that point where people are more comfortable. So if you have symptoms that are emergency symptoms, yeah, you need to call 911 and go to the emergency room. So if you're having, crushing chest pain, you're having sudden shortness of breath or severe symptoms, really anything that is different and seems fairly acute, go to the emergency room. We don't want to overload the emergency room with people coming in with any complaint, but anything that seems somewhat serious, you really don't feel well, you call 911 and you go to the emergency room if it's emergent. And what you don't want to do is drive to the emergency room if you feel like you're having an acute cardiac issue. So, or have someone take you. You're better off calling EMS. Now, there are other symptoms that may be less acute, where your first call may be to call your primary care doctor, if that's an option, and either get in to see them. So from a coronary artery standpoint, as an example, someone's complaining of, I've been noticing, chest pain for the last 2 months when I exert myself, or I notice I get short of breath easily, or I get a little bit fatigued. That might be an appropriate phone call to your primary care doctor, who may refer you to a cardiologist. Certainly, though, you wake up in the middle of the night, you're having crushing chest pain, or you're having chest pain, that's not necessarily something you want to wait till your doctor's office opens to call. You want to go to the emergency room. There are plenty of people who sat at home, thinking they had acid reflux, and we discovered the next day that they had a massive heart attack. So a lot of it is common sense and taking the proper caution. If you're really unsure, you're worried, you're scared, go to the emergency room. If it's something that's seemingly less urgent, call your doctor. Your doctor is either always on call, has someone who is on call for them, that can direct you as to what the right thing to do. The wrong thing to do is to just sit at home and ignore it, and something that could potentially be, emergent.
Mm-hmm. You just mentioned something very interesting to me. You said that sometimes gastric reflux can be confused with a heart attack.
Yeah, we see it all the time. So again, we talk about the typical symptoms of heart disease, the chest pain, the classic elephant sitting on your chest in an acute setting, or the exertional chest pain. But there are people who present with more GI seeming symptoms. So they get, epigastric pain, they get a sense of burning in the chest. If that burning in the chest is caused by going upstairs or by doing something active, to me, that's heart related until proven otherwise. It's not reflux. Now, there's some overlap where that may not be the case, but not all GI symptoms, seeming symptoms, are GI related. So heartburn, reflux, sometimes people get fixated on the symptom of pain. So I'll ask someone, do you have chest pain? No, I don't have any chest pain. Okay, you move on. You ask them again, do you have chest pain? Well, no, I don't have chest pain, but sometimes I get a burn, or I get a tightness, or I get a this. And to cardiologists, all those things are the same until, borne out otherwise. So especially, again, if it's brought in by exertion or activity, whether it's a burn, a pressure, a pain, or tightness, it's all the same. So GI symptoms, just the same. If you have something that feels like reflux, but is triggered by exertion, or there's just something about it that's different, that doesn't feel the same, that is associated with other symptoms, or you're just not sure, don't assume it's GI. Be seen by your physician.
Mhm. And we're running out of time here, so I really encourage our participants, if you have any last minute questions, please write them down in the Q&A or chat box. And then in the meantime, Dr. Brian, what would you say is the best way to prevent heart disease?
I think the best way to prevent heart disease is to start thinking about the issue early. Um, while I don't think, every 20-year-old needs to be in a cardiologist's office to get an evaluation, I do think it's something that we need to talk about, be aware of, and address early. So, and that's part of the reason of having routine physicals, because when you see your primary care doctor, even if you're well and happy, content, no issues, they do blood work. They ask you questions. They might identify particular risk factors based on your blood work that might put you at heart disease risk down the road. And the earlier you are in addressing those issues, the more impact it's going to have on reducing your risk. So, you have blood work done and you have high cholesterol, you have diabetes. The way you prevent heart disease is by addressing those controllable risk factors that you can address: diet, exercise, behavior changes. If you smoke, stop smoking. Regular exercise, 150 minutes of aerobic exercise activity a week. Those are the things you want to start early to prevent heart disease. And sometimes being aware that you're at risk of heart disease is how you prevent it. One of the things I also encourage people to do, that your physicians do as well, is when we see a patient in the office, we actually do a risk assessment of what we think their 10-year risk of heart disease is. And there's actually a formula. You can actually download an app on your iPhone. It's called either AHA risk calculator or something called a pooled cohort equation, where you actually plug in your numbers, blood pressure, whether you have diabetes or not, and other things, that actually gives you a risk score that, based on your risk score, says whether you're a high risk for cardiovascular disease in the next 10 years or not. And we as physicians use that to identify how aggressive we need to be about those individual patients. So bottom line, you prevent heart disease by assessing whether you're at risk for it. And then if you are, addressing the risk factors that lead to it. And that doesn't just mean medication. It means these lifestyle changes that I mentioned before. And the earlier you start, the better.
And I imagine, well, you mentioned this app, AHA is American Heart Association.
American Heart Association, right. It's the exact name may vary, but if you can just put in AHA risk calculator or cardiac risk calculator, it'll come up, and it's something you could download. And if you know your numbers, plug them in, and it sort of gives a sense of what, it could be confusing, and it's more a tool for a physician, but as a patient, some of them actually sort of walk you through, again, reiterate some of these ways to mitigate that risk by affecting your lifestyle positively.
And I guess depending on the score, they will tell you what steps to take.
Yeah, I think the biggest use it has for us, as everyone is aware of statin drugs, which have a bad rap, and everyone Googles and statins kill your liver and this and that, and no one wants to take it. But the truth is, statins have a huge impact in terms of reducing coronary risk, and but it's not appropriate for everyone. So when you identify patients that might benefit from it the most, the higher risk patients, which that calculation can tell you, those may be patients that, even in the absence of having high cholesterol, may benefit from being on statins. I sort of explain statins to patients not as cholesterol medicines, which they are, but I call them anti-plaque medicines. Mm-hmm. So there are patients who don't necessarily have very high cholesterol that could benefit from statins, because statins, independently of lowering your cholesterol, they do reduce your risk of worsening of plaque in your arteries, or plaque becoming unstable and causing cardiovascular events. So knowing your high risk may put you in a category where you should be on a statin, whereas if you didn't have that information, you may think, oh, my cholesterol is this number, it's fine, I don't need it. So that kind of risk assessment is useful in identifying not only people who may benefit from statins, but also people who may benefit from aspirin. Because people used to take aspirin sort of religiously once they turn 50, which we found is not a good idea. It really should be, really based to people who are high risk. And, you could actually do that sort of calculation to kind of identify people who are at highest risk of having, cardiac disease issues.
Mhm. Well, I think that all these explanations, Dr. Brian, have been very good, and I hope that all of our participants here have really enjoyed talking with you, because I learned definitely a lot, and now I'm thinking also what steps I'm going to take to prevent heart disease myself. So thank you very much for joining us today. And then to all of you out there, next week, we're going to have a special session. It's going to be all in Spanish, targeting Latinos, on a Q&A on the COVID vaccine. So if you know any people who speak Spanish and they have questions about COVID vaccine, and if they still are fearful of the vaccine, this is your time to ask all the questions. So please invite lots of people to that. It's a unique opportunity. So thank you so much, Dr. Brian. I really enjoyed having you today. I'm gonna call you again for similar community chats. And to all of our participants, thank you for joining us. And I'll see you next week. Thank you, Dr. Brian.
All right, thank you.
Take care.
Bye-bye.